Thank you, sir, and thanks for inviting me for this your course. My talk today is Smile Biomechanics and Quality of Vision, and have received a small grant to study the biomechanics from Zeiss, but apart from that, I have no other financial interest. One of the biggest questions asked is, when you have many new technologies, is which one to choose, but we are very comfortable with what we have, and that's a bitter pill. Because when you're comfortable with something which is kind of being there with you for many years, it's very difficult to change to something which is new, so which is better now. So in the next 10 minutes, I have only three angles for three titles which I'm going to discuss. One is the optics, the biomechanics, and a last bit of it which was part of a small Zeiss study which we did. The most important thing is when you're looking at any quality of vision study, all eyes are different. And this is a patient of mine. If you have a 6:3 vision, but never unhappy with the kind of quality of vision she had. If you look at this, because our way of measuring the visual quality has remained same for the last 150 years, we never really evolved beyond Snellen chart. If you look at the MTF here, which is nothing but the contrast sensitivity of the optical system only, because if you look at the contrast sensitive function, then it becomes from the tears to the brain, but this is only from the tears to your optic nerve. That means only the optical system. Anything more than 35 cycles per degree is considered very good. Beyond that is very, very good. But if you look at it, one eye is this is 6'3" patient. One eye is 53 and the other one is 27, but still the patient is not happy. So these patients are the ones we need to be worried about when you do any surgery. This is a normal patient, this is not a refractive error patient. But you'll get the same kind of picture probably when you go into the refractive surgeries also. So like Sir said, I joined into the SMILE group very recently, close to a year back. Couple of things which we look at, because we have a lot of expectation when we start. Is it safe? Is it predictable? Why is the wow factor not coming good? Is it really less dry eye? The learning curve, and is it cost recovering? Because we need to earn money for it. So this study was only for my own benefit, because if you are mentally sure of the procedure, then probably you can convey it to your patients. So the optics definitely is slower. I mean, it is not that wow factor. Look at the MTF is 12 compared to a refractive surgery, and say maybe at the end of it, you hardly have a difference between them. So most of the studies I've done is contralateral, means one eye of a patient with SMILE, the other one with femtosecond, just to get this were all ethics committee cleared, consent form was given, patient knew what was happening. One of the factors I realized is it all depends on many factors. One of the factors itself is kind of corneas you have. Patients have stronger eyes, you have more dissection, and you have more time. And also surgeon related factors. And this is the previous one is what we published, that you have a stronger biomechanics, your dissection is tougher, and your quality of vision, what you get is later. Now we actually can correlate with the Corvus biomechanics, and we actually can find out the corneal dissection planes. This is available in Cornea, last year publication. But this is something of my personal thing. What I felt is, as the surgeon gets experience, his quality of vision of a patient gets better. So if I look back at my own results, it was not as good in the initial phase, but I feel that you may at least need this is my take, around 150 eyes for you to reach that tactile sensation where it becomes completely smooth. And once you do that, then you get a plateau, and that's what I think this is where you reach. Probably Sri Ganesh may be reaching out of this slide itself, because the number of surgeries what you do is much more than anybody else. And this is a publication what we did, the ease of lenticule versus the dissection of the plane. The biggest challenge was, when we started, this is Dr. Rushad is here, it was his work, like you had this Bauman's wrinkling, and this is what we felt, and we still believe, that this is one of the reasons why your quality of vision never comes back very quickly on the day one. The question one is, you can't see a Bauman's on a slit lamp, and there are hardly any machines which gives you imaging of a Bauman's, because this is around 3.5 microns. Close to 6 pixels is what you're looking at, a Bauman's layer, and 6 pixels is a very difficult thing. So this you can see that it's just like a flap wrinkles, and more you dissect, more you struggle, the more difficult it becomes. So what we did was we added some mathematical algorithm to it, and we did some we call it as a polynomial algorithms, and we did some Zernike analysis on this quantification, because just showing a beautiful rough image doesn't really make any sense, because you can have one slide, you can have a rough image, one slide you can have a clear image. And this is how the biopterin is. It's a handheld OCT initially used for research, and we use it for most of our work here. So what happened was, again this video doesn't play, there's something problem, but there's nothing great in this. It's just you iron the flap 10 times. When you iron the flap 10 times, and what happens to this distortion, which is just ironing on the flap. And this is what happened. You can see that the distortion actually becomes less. And what we did was, we did one eye ironing, the other one did not. After 1 or 2 rejections from different places, I think it just got accepted yesterday or day before. And this is a kind of vision you get, is your MTF and your quality of vision is definitely better on the first week. Even if you don't iron, nothing really happens. This actually reduces over time, but it takes a little longer time for the patient to get wow factor. So one of the indications is, if you want the patient to get a similar kind of a picture between the group 1 which was ironed and the group 2 which is unironed, which you can see the MTF is very high and statistically significant between the groups, and all of them were matched to refractive error, dissection time, biomechanics, and everything possible, so that there was no bias in our values. And this is what we did. You add a little bit of line on this, and this is the roughness, and this automatically detects. This is a software which we developed, and once you do that, and smooth line fits the Bowman's layer out here, and once you do that, it looks at ups and downs of the Bowman's. This is just like a topography instruments, and then you add colors to it. Once you add colors to it, it quantifies the whole Bowman's layer itself. And this is an automated software for which we wrote the code on this. And this sums up the whole of the Bowman's thing, and this is the graph you get. What is interesting is, even FS has Bowman's wrinkle, and which we don't see because we don't look at it, because we can't measure the Bowman's. But if you look at the FS, it actually keeps increasing because its wound is still changing. But in SMILE, you see the increase and then it becomes stable. So that means that your wrinkles are there, but it does not really changes over time, because by here, I think the wound is already healed. So wrinkling is not only confined to the femtosecond, the SMILE, you also can get it here, but it changes. The other thing is about the nerves. If I just image these 2 eyes, and you see there's a lot of nerves cut and a lot of nerves are preserved and less nerves are cut. So how does it change? Again, if you look at this is a patient, one eye of a patient, where you can, the red lines are the nerves which are cut and regenerating, and here, and if you put a nerve, the machine which checks the nerves here, it completely looks all right. This is just a slide which shows, this is one of our patients where we did contralateral eyes of SMILE versus this. So what does it ultimately end to? Good meibomian glands, poor meibomian glands is very common today, and the quality of vision may actually depend on the kind of dry eye the patient has or pre-existing ones. And this will all change the way the cornea heals also. And this is something which we published. What's very interesting here is that, why do you get ectasias? We all know it's topography, because it's been told to us that topography is the only factor. Lately, what I'm seeing is, this is a case which we discussed with Dr. Ganesh some time back. We're seeing a lot of ectasias, not which comes to you 3 years now, it will come after 8 years, 9 years, because the nerves have not generated. This is a patient who has stable eye, the nerves are normal, very few dendritic cells, lots of dendritic cells. So what we are trying to see is, the ectasia, what is driven now, may be completely inflammatory in nature because of the way the nerves are here. And we took those tears and we started analyzing them in our lab, and we found them exactly the same kind of inflammatory molecules in an ectasia patient, which will exactly what you get it in a keratoconus eyes. So these nerves, that means the patient must have had a near normal topography, or patient has absolutely no topographical abnormality. It must be this what has caused. So this is one of the mechanistic pathway which may cause changes. when we collect, do I have a minute or two, Dr. Ganesh? And if I collected the tears of a patient of a LASIK versus SMILE, and if you do we have just done 3 patients now, we just did a proteomic analysis of it, so I can't be very sure about what the data is coming. What you see is very interesting. SMILE has got lot of wound healing proteins very, very immediately in the surgery compared to more of inflammatory response in LASIK patients. So what does it mean? It means that the SMILE heals in a much faster way, because FLETWIN A has been used as even a gene therapy one to create a better and stronger wound healing, because FLETWIN is very important for wound healing, which you hardly see much in that. This is the same kind of it is what is reproduced all over. So coming to this biomechanics, which I'll just make it very quick, it's about we use different modeling, and this has all been explained about how a Corvus tries to look at the deformation of the cornea, and it has to rule out the other extraocular muscles. And if you look at these videos have some problems. What I'll show here is in SMILE patient, this is a contralateral eyes, how between after surgery, 3 months, 1 month, and before surgery. This is before surgery, and this is after surgery. You see a biomechanics change. And after surgery also, in a femtosecond, it actually gets weaker over time. This is what has been explained. We know that both eyes will become weaker. It's not that both eyes will not become weaker. You cannot say that the SMILE is always going to make it stronger. But here, in 3 months' time, all these patients exactly remain the same. They don't change at all. So that means that wound healing is so beautifully happening out here that it does not change compared to here, but it keeps changing. Maybe I do it after 6 months, you may have a different graph out there. And this is the picture. And this is if you do an inverse FEM modeling, the graph is already straight at some point, because it means that the cornea is getting stable and it's not changing much. So this is my last slide. This is what we did as a crush injury to see what is happening when you add an insult to the eye on an eyeball. This is what I said. I got 2 or 3 licenses from Zeiss to do the study, and when we took them to the lab and we started analyzing them, and to sum up here, what happens is when you do a SMILE versus FS on a crush model using an eyeball, you see that's the proteins which are responsible for a faster and a stronger wound healing gets activated much faster than in a laser when you cut the corneas. So from just a small example from a different point of view, from a healing is what I wanted to discuss. This healing is probably the reason why you get more stable biomechanics in a much earlier phase of SMILE compared to a later compared to a femtosecond laser. I'm sorry for taking few minutes time, sir. I'm done with this. Thank you.